All right, let's dive into mastering the art and science of wound assessment and documentation. This is such a fundamental skill, and when you get it right, it can literally change everything for your patients. So let's get right into it.
This quote really hits the nail on the head. We're not just filling out paperwork here. Every single word you write, every measurement you take, it's a critical piece of a clinical puzzle. It guides the entire treatment plan, it makes sure everyone's on the same page, and of course, it's a vital legal record.
So, why is this such a big deal? Well, get this. In the US alone, 6.5 million people are dealing with chronic wounds. I mean, think about that for a second. That is a huge number. It pretty much guarantees that you're going to see patients who need this expertise, which is exactly why getting your documentation right truly matters.
Okay, so let's start at the very beginning with the absolute foundation of any good wound assessment, pinpointing exactly where the wound is and just how big it is. Seriously, these first steps are the bedrock for everything else that follows. Look, you absolutely cannot be vague here. Saying something like right ankle just doesn't cut it, especially if a patient has more than one wound. Is it the inner ankle, the outer? We have to use precise anatomical terms, like medial aspect of the right malleolus. It just eliminates any and all confusion, and it means the next clinician knows exactly which wound you're talking about. Now, for measuring the size, we need a system, right? A standardized approach so that my measurement today is going to be perfectly comparable to your measurement next week. And the clock face method is the gold standard. Just imagine the patient's head is at 12 o'clock and their feet are at 6. Length is always measured from 12 to 6. Width is from 3 to 9. And for depth, you just gently insert a sterile applicator into the deepest part. It's simple, it's repeatable, and it's accurate.
Now, get this, wounds aren't always just these simple little craters. Sometimes they have hidden depths. Tunneling is when there's a narrow channel, kind of like a little tunnel, going out from the main wound. Undermining is when the edges have lifted away from the tissue underneath, creating this kind of lip. And guess what? We use that same clock analogy to describe them. A tunnel might be 2 centimeters deep at the 7 o'clock position, and undermining might go from 8 o'clock to 11 o'clock. Documenting this is absolutely critical because this hidden dead space is a prime spot for abscesses to form.
Okay, so we've covered the where and the how big. Now, let's move from the outside of the wound to the inside. This is where the real detective work kicks in. We're going to decode the clues that the wound bed itself is giving us about how well it's healing. Think of the wound bed like a landscape. And on that landscape, you've got 4 main players. There's the healthy, healing granulation tissue. That's the good stuff. Then you've got the non-viable slough and eschar, which are basically roadblocks to healing. And finally, there's epithelial tissue, which is kind of like the finish line of wound closure. Let's break each one down. Oh yeah, this is what you want to see. This is the good stuff, granulation tissue. See how it's beefy red, kind of bumpy and moist? That bumpy, granular look is from all the new tiny blood vessels forming. When you see this, you know you're looking at a healthy, healing wound. This is always the goal. Now, on the flip side, slough and eschar are barriers to healing. And these two get mixed up all the time, but they are totally different. Slough is usually moist and stringy, and it has this yellowish-white color. It's basically a mix of dead cells and gunk. Eschar, on the other hand, is dry, thick, leathery, and dark brown or black. It's literally dried up, dead tissue. They're both bad news for healing, but you have to think about them a little differently.
And wow, this picture just says it all, doesn't it? On the left, you've got that classic, wet, sticky-looking slough. It's clearly just smothering any healthy tissue that wants to grow. And on the right, that is textbook eschar. See how dark and leathery it looks? Seeing them side by side like this makes the difference crystal clear.
Okay, listen up because this is probably one of the most important clinical decisions you'll make with eschar. You have to figure out if it's stable or unstable. Stable eschar is dry, hard, and stuck on tight, with no signs of infection around it. Unstable eschar is boggy, kind of squishy, maybe draining, and you'll see signs of infection like redness or warmth. Now, here's the golden rule, the one exception you have to remember. You do not debride stable eschar on a heel. It's acting like a natural bandage. Unstable eschar, though, that's got to go. So we've looked in the wound, but the story doesn't end there. We've got to read all the other clues the wound is giving us. And that means looking at what's coming out of it, the exudate, the state of its edges, and the skin all around it. These are all vital parts of the story.
The drainage, or what we call exudate, tells its own story. Is it serous, clear and watery? That's pretty normal in early healing. Or is it purulent, thick and cloudy? That's a classic sign of infection. Sanguineous means there's active bleeding, and serosanguineous is that normal pinkish mix. The type of exudate is a direct window into what's happening inside that wound right now. When you're documenting, don't just say what type it is. You have to quantify the amount. Is there just a tiny bit? Scant. Or is it moderate? Or is there a ton? Copious? This helps you pick the right dressing. And hey, here's a pro tip for you. When it comes to odor, only assess it after you've cleaned the wound. An old, dirty dressing will always smell bad. We only care about the smell that's coming from the wound itself. All right, you gotta lean in and look really close at the edges of the wound. If you see this, epibole, that's a huge red flag. It means the edges have rolled under, creating this little lip. This is a telltale sign of a chronic, stalled wound. The cells that are trying to close the wound, they just can't climb over that rolled edge. They hit a wall and stop. So the wound just won't heal until that edge is fixed. And finally, please don't forget to check out the peri-wound skin. That's the skin around the wound. Redness, what we call erythema, could mean a spreading infection. If the skin feels firm, that's called induration, and it can also signal trouble. And if you see maceration, that white, pruny look, it tells you there's way too much moisture and it's starting to break down healthy skin. The peri-wound tells you a ton about moisture and inflammation.
Okay, we've gathered all our clues: location, size, tissue type, exudate, the edges, the peri-wound skin. So what's the final step? We've got to pull it all together and synthesize this info into a clear, concise, and really powerful clinical note. And I've got a super simple 6-step framework for you. If you follow this every single time, you literally can't go wrong. Start with location and measurements, then describe the wound bed in percentages, note the exudate, describe the edges and the skin around it, and finish up with any odor or pain. It's a repeatable recipe for a perfect note every time. So what does that look like in the real world? Let's check out this example note. It follows our framework perfectly. It gives the location and the exact measurements. It quantifies the tissue types, 75% healthy granulation, 25% slough. It describes the scant, serous exudate, and confirms the peri-wound skin is healthy. See? This note paints a complete and crystal clear picture for anyone who reads it. And if you like mnemonics, here's another awesome tool for your toolkit: the time framework. It's just a great way to structure your thinking. T's for tissue, what's the bed look like? I's for infection or inflammation. M is for moisture balance, is it too wet or too dry? And E is for the edge. Are the edges moving forward or are they stalled? It's a super quick and effective mental checklist. All right, let's boil it all down. If you walk away with just a few things today, let it be these 4. Number 1, always use percentages for tissue types. 2, if less than half the wound is that healthy granulation tissue, that's a big warning sign. 3, the golden rule: protect, stable, heal eschar. And 4, slough and unstable eschar are roadblocks that have to be removed for healing to even have a chance. Look, at the end of the day, your documentation isn't just about checking boxes or filling out forms. It's the story of your patient's healing journey. It tells the next person what's happened, what's working, and what needs to change. So the question I want to leave you with is this: what story will your next note tell?